Brilliant, thank you. So we've just started recording. So we're here to kind of talk about through the opportunities and challenges of prevention for SUDI in our works. And I see Stacey, you would like to go first. So over to you, please.
I don't address safe sleeping in my routine sort of work, but obviously as SUDIC nurse, I do it with the parents that have another baby following a previous SIDS or SUDI. And I actually had an issue last week where we don't come under the CONI schemes in our geographical area. So we've lent a parent a monitor, a Snoozer Hero monitor. And actually, I think part of the thing for me is how open and honest are professionals with parents following the death of the first child, because we have to be very gentle and we also never want to cause upset to these parents. But actually, this mum hasn't paid attention to the safe sleeping advice still. And I just wondered, for me, how gently and what sort of advice do we approach with those families? Because she's very quick to blame other people and put down to the immunisations, but actually baby being put to sleep in a bouncer that wasn't flat and baby's head was forward. And he's got a lot of anger then towards other people. We've had other families where they've had a previous baby. Everyone has reiterated the safe sleep advice. They've ended up on the ward with the second child, and then they've been co-sleeping in the bed with them, and staff have had to say, come on, you need to take baby off you. So for me, it's around that education, but how do we do it to remain gentle and empathetic, but then get that message across that actually what you're doing isn't safe? And I find that a really hard area and really grey.
Thank you. That's a big challenge, isn't it, of getting the messaging right. Does anyone want to come in on that? I know from my thinking of what you're saying, Stacey, it would be about the compassion as well as empathy and things as well. But it's that compassion of realizing that actually the worst thing that could happen is for that mum to lose a second baby through those choices. And ultimately, having those conversations, whilst very difficult, are so important. And that's where the CONI scheme really kind of comes into its own, isn't it? So not having that in your area can be really tricky, because that's your opportunity to kind of talk through in a non-judgmental way. Obviously, you don't want to say you did this last time and it was wrong, but about opening those conversations of saying, actually, the evidence says this is what is best for a baby. And it's about trying to meet that in every way that you can. And I think that CONI nurses in particular get very good at delivering those messages because it's something they do all the time. So I don't know if maybe contacting the CONI team at the Lullaby Trust could maybe offer some words, if nothing else, to help you with those conversations. But yeah, we've got the CONI scheme in Surrey. I don't know if we've got anyone from Surrey who delivers CONI here. No, that would be wishful thinking, wouldn't it? Does anyone else have anything on those challenges of conversations with families after the death? Suzanne?
Yeah, following on from what Stacey said, I think parents sometimes feel as though they're talked to, don't know, or dictated to, rather than part of the conversation. And they do feel a bit blamed, so they sort of turn right off then, don't they? Perhaps involve them in the conversation, say, well, and find out the barriers of why they're not doing it. Because like I think you said earlier, a lot of the time is because the babies aren't sleeping, aren't they? And then maybe at the end of their tether and they're doing unsafe sleep because that's how they can get a bit of rest from the baby as well. But it is difficult, isn't it?
Yeah. Claire?
I think sometimes just trying to be really strengths-based. So looking at all the things they are doing well and talking about them first of all, that sort of helps break down some barriers, doesn't it, if they don't feel that you're getting at them.
Yeah, definitely. Thank you. Strengths-based is always the best way, but it can be really difficult, can't it, sometimes, to find those strengths if you're in a difficult situation. I know this is very difficult to get the conversations going because everyone's always a bit nervous to speak out, but is there anything else on that, or does anyone have anything that they've thought of in terms of opportunities or challenges at all? Amy?
Hi. Do you ever give anything visual out when you go to houses? Obviously, when you have this discussion with parents, they may sort of, like you said, be in denial that it's happened previously. But if you were to sort of show them visually with the Lullaby Trust leaflets or anything, and they might think, oh well, actually I did do that last time, I'll think about not doing that this time. do they ever get anything visual given to them?
I think that depends on your organisation, I would say. So I know that when I used to be a health visitor, we used to give out hundreds of leaflets. And I know in recent times, leaflets have got less and now they're given more of a link. And I don't know, I get given links all the time and I don't always click on them. And yet I'm quite keen to read these things, but sometimes you get link overload, don't you? And you don't. But we still give leaflets in terms of our work. But I don't know if anyone from a health visiting point of view, do these leaflets get given? Because it's our health visiting team that ultimately deliver Coney in Surrey. Rachel.
Hi, I'm a health visitor in Surrey area.
Perfect.
So just to clarify, we don't give leaflets as such for unless you're really doing a lot of intense work and you've identified a parent who's got maybe some additional needs and they need a different way of giving them information. So that's still given, but most of the information is in the red book on our websites and things like that. I just wanted to sort of comment about, because I had a very similar case to Stacey in my area 3 years ago when we actually didn't have pony service going. And the family are from a different culture, young parents who's also got learning needs, and maternal and grandmother was very, very strongly involved in decisions and about looking after the second baby. So I think just that cultural barriers involving everybody else who's involved in the looking after that child is so important in just trying to, because mum became very protective after losing the one child, so she was not going to put him away from her. And it's very, very difficult having those conversations, but it's just little and often and be compassionate. Yeah.
Yeah, absolutely. And little and often in itself can be a barrier, can't it? Because not a lot of services have the opportunity to drip feed into families. You get a 1-hit or a 2-hit kind of opportunity to talk to people. So yeah, drip feeding, whilst being the kind of gold standard, is not always achievable, is it? Unless you're able to see that family regularly. Yeah, thank you. I think the other thing that you're saying there about working with families is it's ultimately about being trauma informed, isn't it? So the death of a child is hugely traumatic. So just making sure that we keep that trauma in our mind, that they're going to be scared, they're going to feel stigmatized, shamed, all of those sorts of trauma events, just from the fact that they're now trying to cope after the loss of a baby. Yeah, thank you. Lotus.
Yeah, it's also in addition to the visuals, because that was also my point about the visual. I know it's not part of my role in terms of doing the co-sleeping, but I do, as part of my safeguarding role, we do link up with A&E, like any under like 28 days or babies that attends A&E. We try and get the clinicians to just remind them as well about the importance of the safety practices and safe sleeping. Rather, and I am aware that our maternity mostly are involved with that. The midwives usually is part of their discharge process about the co-sleeping and like safe sleeping practices. But I was just wondering if our approach is like, more in the visual, like a representation, like a doll, that sort of like part of the health visiting services. Like, because in the ward, we when we teach parents in terms of like like those teaching the BLS for babies, we have a doll per representation. So whether in terms of positioning, if that would more, when they see visual, like positioning of the baby, it would they would be able to remember that rather than just looking at a photo or in a leaflet. And we know what happens to leaflets once they put it inside their bag. That's it. That's the end of it. But when they see an actual doll, actually, that's showing them that what happens to the neck, and if they're like sleeping on this, whether that's more have an impact on their memory for these parents. So yeah, so just thinking about that, really. Yeah.
Yeah, no, absolutely. That's a big opportunity, isn't it? However, I would say if you're lost a child, you've got to be really careful with dolls that they don't trigger memories.
Yeah,
so if it was
absolutely.
before the death, so if you're preventing SUDI prior to their, a death, then the doll is absolutely a really good tool to kind of show that head positioning and things, isn't it? Yeah, brilliant. Thank you. Kim.
Hi, Nicola. I know you've touched on this already.
Oh, Kim, I can't
Sorry.
hear you properly. I don't know.
No, I can't hear you, Kim. Sorry.
No,
You're really quiet.
I don't know if it's your mic on your headphones.
It's because my little thing's
Yeah.
on top of my head.
Yeah, I didn't like to say
better.
that.
Oh, I'm such a wally. I do apologise. No, what I was going to say was that I think, coming from a health visitor background myself, I think it's about the kind of what I like to call the hierarchical practitioner. So it's about the communication skill set, it's about the tools that you have, and it's about, I used to work with a health visitor who every time she would go into a home, not in Surrey, I might add, every time that she would go into a home and she saw a baby maybe not flat on their back, she'd say, oh, me and you are going to fall out, to the parents. So once you take that approach, and then you're kind of on the back foot already, parents aren't going to be listening to you, and it's about not presiding over parents and their families, because I think that sometimes we think we have a right to do that, and we absolutely don't. But I have seen it happen in practice all too often, sadly. So I think it's about thinking about not being the hierarchical practitioner, and thinking about what you have in your communication toolkit, and not sort of being authoritarian over parents, because I think that will, if you don't deploy any of those, then you're already going to get on really good grounds with parents, aren't you? And you're going to start building that professional trust, and they're going to want to actually listen to what you have to say, and using that motivational interviewing to find out what they know about it. But yeah, it's something I come across all too common. When we talk at people, we don't talk with them, we talk to them.
Yeah, particularly in medical circles, that happens a lot, doesn't it?
Yeah, definitely.
Yeah, I think I appreciate. I used to often be told, "Oh, you're the health visitor police," as one of the things that parents used to say, and I used to have to work really hard to undo that first before I could even try to get any messages across, because they don't trust you to start with, and you've never met them before. But it's all to do with those previous experiences they've had, isn't it, with other practitioners?
Definitely, yeah.
Yeah, and that comes back to that. I don't know if people have come across it before, but we've mentioned it in 7-minute briefings in Surrey. It's about epistemic trust, and that's about trusting people to take the advice that they're giving you is something that is important to you. So trust is it's about the fact that you value what they're saying enough to listen. And if you don't have that kind of trust in there already, then what they say will bounce straight off, because they don't value your opinion to start with. So that there's a lot of that in safeguarding, actually, talk in the articles and stuff to support social workers in building that trust with families. Because I can only imagine, as a social worker, your reputation precedes you before you've even made the phone call, probably. So it's really hard to build that trust with those families sometimes.
And then they're just wasted opportunities, Nicola, aren't they? There are opportunities that you have, you have that kind of, that MEC kind of approach, making every contact count. But if you lose that opportunity and that kind of window of opportunity, then it's such a shame, because you could have done so much work,
Yeah.
Yeah.
Yeah, absolutely. And then being the practitioner that loses the window for the next person is not a place where any of us want to be as well, is it? So yeah, thank you. Amy.
Hi, I'm a JAR nurse at Sheffield Children's Hospital, and I'm also the Safe Sleep lead as well for the trust. And what I'm trying to do is, well, we have got Safe Sleep champions on all of the wards and day units as well now. So it's our duty of care to ensure these babies are sleeping safely. So I hope every nurse on the ward, especially the champions, is really pushing and encouraging these families to sleep safely. If they have any trouble or are really struggling to get through to parents, I'll happily go down and have a chat with the parents, take them some lullaby trust leaflets, and sit and have sort of a gentle but frank conversation with them about safe sleeping with a child, and especially how being an inpatient, potentially having temperatures, things like that, impacts the risk of that. We have a smoking cessation team that comes around every day and speaks to parents. So I'm also liaising with them to try and ensure that they're sort of putting across how much smoking increases the risk of SUDI. And recently I've started doing some training sessions with student nurses as well. I know when I trained, child death was never really discussed. It was all about getting the child better. So I'm ensuring now that I am talking to students, informing them that sort of about safe sleep, about SUDI, encouraging that they know about it before they go on placement and while they are on placement, and just making sure the nurses on the wards do it as well, because obviously these students are learning from us. I did an audit a few months ago. We are still not amazing at safe sleep in the trust. We're still making nests for babies. We are still got lots of things in the bed. So I'm really trying to push safe sleeping and the nurses to do it, because ultimately these students are learning from us, and if they're seeing us do it, they're going to do it as well. So I'm really going to push to try and get the message across to the student nurses in the training about SUDI and safe sleeping.
Yeah, that sounds wonderful, Amy. I think the other thing you were saying there about it not being something that's talked about, I think you only think about child death when you experience a child death in your professional working life. It's not something you ever think would happen because it is quite rare. And in Surrey, we have between 60 to 80 deaths a year. So it's not huge given our population, but actually 60 to 80 families who are left without a child. If any of those could have been prevented, then it's our duty to kind of do so. And I think that raising that awareness beforehand means we're prepared to kind of have those conversations and deal with it. And what you talked about, the modelling for students, is really important. I think we need to model for everyone, model for parents, model for, Nicola and I were having a conversation with someone from who works in a nursery about babies in the nursery and modelling that with them. The young children, the toddlers, when they're putting their baby down to sleep in the cot, you can make sure they're on their back or whatever. Those little messages you can kind of drip feed in from any chance. So modelling is definitely something. Yeah, it's key to everything. Thank you, Rachel.
Speaking of students, I've got Hannah with me, who's a midwifery student, and she's got something really important to share.
Hi, I'm the first year, and I just feel like there's been times that I've worked on a postnatal ward or on delivery suite, and doesn't seem to have been, there's a kind of assumption that if you've got previous children that you know all the guidance. So, and I remember overhearing, it was only just by chance that I overheard a woman was having a conversation with her partner about changing the tog duvet for the baby that they bought because it started to get hotter. So they were like, she said, I think I need to get, and I was like, no, you can't have like duvets in a baby's bed and stuff. But she said, it's, my other child, but he was like 12. So that gap between 12 and now, the guidance is so different. But I guess along the way, it's obviously just been assumed that because, her grandmother would have been 2. So then it's like, they know the guidance. So we don't really need to have these conversations with everybody.
Yeah.
And it's just, that was a concern. I've heard that a couple of times where parents have said, I've done this with my previous child, but the age gap and guidance was so different.
Yeah, absolutely. That's wonderful observation to have as a student, because that's phenomenal, and that would change your practice forever, I would say, is that assumption that people know what they're doing. And I deliver training to lots of people, and I often see people panic because when I'm talking about things, you can see clearly that they've done it themselves as a professional with their own children, and it's about not making it so that that's a problem. We all do things. We all, I am a nurse and I choose to have sugar, and I know that it's bad for me, but I'll still have it. Same with coffee, those sorts of things. I know that they're no good to my body, but I'll still do them. So it's that assumption that even if we know something, it doesn't mean we're going to follow it anyway, but it's about making it really clear why this is important. And if someone said to me, if your baby sleeps on its back versus its front, that, we've reduced the death rate by 80% just by making babies sleep on their back to their front, I would absolutely make that choice. But if someone says to me, you're going to gain 2 pounds if you eat that, I'll be like, nah, I might, it's a different mentality, isn't it, of thinking. And I think grandparents and previous and all of that is such a big part of a family's life, because they just ultimately want some sleep, don't they, in those first few weeks, because it's so tiring that they'll do whatever it takes to keep those babies calm and quiet. And yeah, no, absolutely. And I think that assumption, when I did a local child significant practice review for a child, the mother actually had 5 other children. And she didn't know some of the guidance until after the death of her child. And she said, I wish someone had talked to me about this. I just didn't know. And she may have been told it. She may have been told it 3-4 times before, but it hadn't set with her. So sometimes it's about not just giving those messages, but how they're received the other side, isn't it? So you might say something to someone and they might forget about it. But if you say it again, they might remember it. Or like we were talking earlier about the doll, that might be the one thing, as Lotus was saying, that triggers that family to remember something. And we know that practical is always much more memorable than listening or watching, isn't it? So yeah, no, absolutely. Thank you. That's massively insightful for someone who's a student. So congratulations, and keep thinking like that for the rest of your professional career, definitely. Stacey.
Yeah, just to add on to that, nobody once ever spoke to me about safe sleeping during my pregnancy or from the health visitor at any point, because they saw that I was a children's nurse, saw that I did, the SUDI nurse role, which I'd only been in post about 1.5 years, I think, when I went on maternity, so still very junior. Not one person, I think they just assumed I knew it. So it'd be interesting, actually, I think, to ask colleagues, within paediatrics and things, actually, did you experience that? It'd be interesting to know if there is that assumption made by a lot of professionals. If you did like a bit of a quick audit, I bet it'd be quite revealing, actually, wouldn't it?
Yeah, definitely, hugely. Thank you. I think that's a project in itself. So we'll see how we can take that one forward. Thank you. Amy.
I was just going to say, well volunteered, Stacey, for that audit. So I was just going to comment on what you said, Nicola, about the baby laying on their tummies rather than their backs. I've recently just had a family where baby was sort of fallen asleep on mum's chest, and we presume has rolled off mum, and was found face down, but with vomit around her mouth as well. And there was quite a significant history about reflux. And sort of my concerns, obviously I'm not a health visitor, and I won't be doing any sort of checks on this family in the future, but my concerns is this mum has found her baby face down with vomit around her mouth. Just the compliance with the families that are not going to trust that information anymore now, and how can we just promote it, and if they don't follow it, sort of that's their choice. Just promote it as much as possible, because I think now this mum's going to think, right, next time I'm going to let my next baby sleep on a tummy, because my previous baby that's died was on a tummy and choked on a vomit. And it's just that giving them the evidence, but them sort of still not believing it and wanting to follow it.
Yeah, absolutely. It's an informed choice, isn't it? You can only make them aware of the information and support them in those decisions, but ultimately you can't make them do anything, definitely. And I think that the role of the health visitor, definitely, and if there was a CONI scheme, that's really your kind of key moments to explain to parents that how the baby's head shape supports them not vomiting and then choking on it. So having those discussions will be really sensitive and really difficult for whoever has to have them, but key to helping that mum to overcome those thoughts in the future. And they may not happen, but people can try, I guess. Yeah, thank you. Emily.
Yeah, I was just I might be Stacey's first audit person. So I'm the Child Death Review Coordinator for Surrey, and I had twins who were on the NICU in Skaboo for 3 weeks, and it was just the same experience that the neonatal nurses and the health visitors, whilst I was there, said the same thing, that they didn't need to go when they realised. I knew the neonatal nurse, but the health visitor, when they realised what my role was, said exactly the same. They didn't really need to go over the SUDI stuff because I should know it, so I actually had to ask them to do it. And I just found it interesting because obviously my girls were on their front, wrapped in blankets, hats, so even their sleeping environment when they were speaking to me would have been completely different when I went home. So it's just to echo what Stacey said, that they think they really just brushed past it.
Do you think, Stacey and Emily, that could be fear because they think you know more than they do, maybe? So it's breaking down that fear that actually, no, treat me like anyone else, and I need to kind of hear it, because sometimes hearing it is different to thinking it, isn't it? So. Yeah, and I especially asked and said, no, can you, because me taking 2 little babies home is very different from sitting in meetings and thinking, oh yeah, I know it. It's you need someone to embed it in with your children when you're going home, and especially just because they were, like I said, they were on their front, they were just completely different to
yeah, is that yeah? So I don't know. It might be fear, or yeah, I just don't know.
Do we have anyone on the call who works in a neonatal unit, or don't know if we do? I'm just thinking of those transitions from like SCABU to home and through the neonatal. Oh, look, loads of people. Rachel.
Hello, I used to work on a special care baby unit and a neonatal unit, and you're very right. They used to have like a cut-off age for the gestation, so that when they were due to be going home, we would stop swaddling them. But the reality is, a lot of parents didn't get this, and a lot of the older nurses didn't practice it, and it looked like you're being a lot kinder when they'd give them their little mess and tuck them all in, and they've got their hats on, looking like they're about to go skiing with their thick cardigans. So it seemed like a very sharp contrast to advice when they go home. Yeah, so it was.
Oh, I think, has Rachel frozen for everyone? Yeah.
What
So,
actually happened.
are you back, Rachel?
Oh,
Yeah, you froze for a little bit. Yeah.
Oh, how annoying! Sorry. Did you catch any of it?
Yes. Yeah. Up to like you were saying
Oh.
about them going home, and then yeah.
Yeah, so it was quite a sharp contrast. I don't know if it's a bit more different in recent times. But I think most of the time when you are doing all the swaddling and the snuggling and the blankets, that seems like a much more kinder thing to do rather than the advice of the safe sleep that you're putting in this empty cot on their own. The reality is how many babies actually do that really lovely sleeping in this safe sleep environment.
I think Rachel's frozen again, but yeah, no, absolutely, totally get that. The when babies are warmer, they tend to sleep longer and deeper as well, don't they? So having that hat and that cardigan and the nest is a good way to make them quiet. But you say about that being kinder, but actually it's not kinder when they're at home, is it? It's kinder to have them in that safer sleep environment for protection. The one thing I would say is one of the biggest risk factors that comes up through all of these is actually being premature. So ultimately this is a group of babies that we need to be focusing on, because that's a risk factor in itself for SIDS and SUDI. So yeah, we will be having a session, a lunch and learn session with a maternity neonatal kind of focus in the future. So we'll be looking for people who want to be involved in delivering that, and how neonatal units and maternity units can support that. So if anyone's interested, do email Nicola and we can get that sorted in the future. Stacey. Oh no, sorry, Becky.
Hi, I used to work on neonates for about 13 years before the SUDI role I'm in now, and I still try and go over there for do safer sleep, and it's probably been one of the hardest wards to get them go along with things with me. It's been really, really difficult for get them all on board. That's probably the most difficult ward I've had out of all the children's wards, PICU, neonates and maternity, which they're the most vulnerable babies as well.
Yeah, why do you think it's harder?
I think it's just habit. I think the nurses are that used to wrapping them in nests and putting 3,000 blankets on and hats because you think they're going to go cold. And then they don't get the transition bit where they need to tell parents when they go home they've got to just have the one blanket, no hat inside, don't let them sleep in the car seat. And I think it's partly that, and I think it's staffing as well. I don't think there's the time to sit down and go through it properly with parents, which is really, really sad.
Yeah.
So at the minute, I'm trying to get the healthcare support workers to do family craft sessions rather than rely on the nursing team.
No, it's brilliant to try and get that going. It's sad that that's the kind of barriers that you're facing with getting these messages out. I know as a health visitor, one of the things I used to see a lot was that families are always worried their child is cold, their baby's going to get cold, and trying to keep your house between, I mean, it used to be 16 to 18 degrees when I was a health visitor, and now it seems to be 18 to 20. So we've got a little bit warmer in society about how to keep our babies warmer. But actually telling a parent to have their house at 18 degrees, they panic and they think their baby's going to freeze. But actually, like in Sweden and places and Norway, they put their babies outside to sleep in the minus conditions because it's good for them and in part of their culture. So yeah, it's very difficult to get people to understand when a baby, because babies can shiver when they're cold, but they can't sweat when they're hot. So you're almost overcompensating and putting them at more risk by overheating them than if they were cold.
Yeah, and I think on neonates, you're that obsessed about keeping them warm when they're out for cuddles or anything. You do the temperature that regularly, and then all of a sudden they go home, and the parents must be so worried about keeping them warm. They almost overheat them then.
Yeah. And our houses are so well insulated and heated these days. It's not like when we all had single glazed windows with, gales blowing through and stuff. They're all so hot now, if anything. Yeah, thank you, Becky. Stacey.
Yeah, I think I've got 2 points really. So obviously deprivation. You say, oh, well, homes are well insulated. Well, we're in Grimsby and that isn't the case. We've got a lot of families that are living, it can't even afford to put the heating on and things. So then they like overcompensate. Or they're in a property where they've got broken windows or, old windows and the seals have gone and it gets freezing cold in the winter. And then the second point is social media impact as well. I obviously work in safeguarding. I'm SUDI nurse, so I like a bit of trash telly on an evening. I'll hold my hands up and admit that because I zone out. But when you're watching things like, Sam and Billy Fairs, the mummy diaries, and they're openly co-sleeping, and they're putting that in the media, they're putting that on television and social media. I do think that has an impact on people. You're seeing all these photos of babies in houses with hats and things on. When I had my little girl, I probably had about 15 hats. Every set comes with hats. She used one. So it's getting out of that mindset, and I think that's got a big impact on it now, to be honest.
Yeah, no, absolutely. I see Amy's just put in about sleepyheads and all the colourful patterns. It is, social media is a big thing about these pictures of babies looking idyllic and sleeping, and there's also this misconception in the society generally about the fact that a baby that sleeps for a long time is a good baby, and actually a baby who sleeps for an hour is also a good baby. So it's undoing that mindset, isn't it? That actually having a baby sleep is not whether it's good or bad. It's just a baby. And if anyone's ever breastfed, that it's not, an hour is good. We'd be quite happy if the baby slept for an hour before you go on to the next feed. So yeah, absolutely. Social media is huge. And I think that the more we get these messages out, hopefully in time influencers will follow safe sleep when they're advertising it. So co-sleeping, like you say, if they're promoting co-sleeping, that's brilliant. But as long
Hi there, I'm a midwife from Guildford, working with the safeguarding team, but I've a few years experience of community. So we're quite lucky in that we can be drip feeding that information. So there's certain periods in pregnancy and then afterwards that we have to discuss safe sleep. So 31 weeks generally, we speak about sleep and signpost them to BASIS and Lullaby Trust, and then it's discharge from the postnatal ward day 5 and then discharge again to the health visitor. But I think it was definitely really important what you said about becoming desensitized to it and it being yet another tick box. And I think that's really important to try and get into the training, especially if the new midwives coming through. Of just like you said about, how sleeping on the back has reduced that risk by so much, actually making the points, not just mumbling them while you're doing something else. I went to a training day a while ago where the health visitors said how important it was to fill in the red book. And I think with all the digital stuff that we now have, we fill it in our digital bit. And then that had fallen by the wayside, and actually drawing the parents' attention to the red book and filling it in there. And yes, some midwives do then say, well, we're duplicating what we're doing, but actually it's something that the parents can go back to. From our point of view, with you were saying about special care, we've got a couple of sort of midwife support workers who are now working as outreach. So when premature babies have been discharged from our SCABU, they will have that outreach as well. So they have that opportunity to discuss the safe sleep, which is really useful. That's only come in the last year or so at this trust. And then something that since COVID, we're now trying to get back to doing a few more visits. So because I'm now in the safeguarding team, anyone that we deem as red or amber risk for safeguarding, we are trying to get the community midwives to do an antenatal home visit so that we can try and tally that with safe sleeping, so that we can just see, have a reason to go and look in their bedroom and discuss that a bit more fully. But it's definitely something that needs to be sort of reiterated to new midwives and in our maternity updates and on a yearly basis. I think that important so that people don't get just a bit not bored but saying the same thing.
Yeah, no, absolutely, thank you. And I think the other thing is when you're new in post or you're new to your speciality, it's kind of having nuanced conversations is much harder if you don't have the background and the kind of basis to bring it on. So actually, the more experienced you become as a midwife, the more you know which points you have to make more of an effort with than others, and which bits you can avoid based on what you're seeing and what you're hearing. So that's also something that without experience can be so much harder. It's not impossible, but it's harder, isn't it, to know what to tackle. And it sounds great, the work that's going on. And I know that COVID had a big impact on home visiting and midwifery and things coming into hubs and then going back into the community. And so it's rebuilding, isn't it, almost a lot of the services that got changed through COVID. Thank you. Stacey.
Yeah, I was just wondering, what's the advice regarding vaping and co-sleeping? And do many people touch on that? Because we had a case last week as probably going to turn out to be a SIDS, is what my gut instinct is telling me, but heat within the flat and things. But mum was a vapor, and I just wonder if there's much out there on that at the moment.
Nicola, did you want to? Because we've been going around this a lot, haven't we?
Yeah, we spoke to Peter Fleming about this from the National Child Mortality Database, and he wants us to report if there was vaping in the household, because they're collecting that data. So it's really important to record it. He thinks, well, what he's talking about, because it's nicotine that suppresses the arousal mechanism in your brain, and you still get that from vapes, won't you? So there's a working hypothesis that whilst vaping isn't as dangerous as smoking, there are still those risks there, aren't there, around that arousal mechanism. And so that's why they want to collect the data to see about the links. That's really good, Amy, to hear it's discussed in the CDRMs. I think it's about us collecting the data, isn't it, for now?
Yeah.
But I think we'd be saying to families it's vaping and smoking. I think that would be sensible, wouldn't it?
Thank you. Yeah, I know I had a discussion with a respiratory consultant from one of the London tertiary hospitals, and he was talking about learning about vaping in real time, so that we don't know the risks, but we're seeing all these complex presentations that are coming out from people who have been vaping. And unfortunately, we can't kind of predict anything yet because we haven't got the evidence. But he said there are definitely things that he's seeing in terms of patterns and trends in his cases that he's working with. And he was in particular at that point, he was talking about teenagers vaping rather than parents vaping with babies, but it was the fact that he was making the point that we just don't know yet. So it'll be about looking and collecting and researching, and yeah, because it's all so new, isn't it, vaping? The other thing is we were talking about vaping from a step down from smoking versus vaping straight off. So vaping was never meant to be a thing of its own, was it? It was meant to be the step down off from smoking. And now people are vaping for the first time, having never smoked, and the impacts that might have too on the population. Amy?
I think what we're finding is that a lot of families, because it doesn't make us smoke and it doesn't smell bad, a lot of people think it's safe to do around babies and children. But like you said, it's sort of the same impact, but because it doesn't smell like cigarettes and it doesn't stain your walls and things, people do it more indoors than they would smoking at the door, for example.
Yeah, it's an interesting thought. I think it's just about collecting it. We'll have to see what happens, but yeah, I think that's a bit of a worry, isn't it, that it's seen as safer almost. I didn't know, Nicola, I know you sometimes talk about smoking cessation and the long-term plan and stuff and what it looks like in Surrey. Would you be able to kind of talk about that a bit?
So I think, sorry, I can't remember who was talking about the work in Sheffield with the smoking cessation every day. That I think that must be part of the offer under the NHS long-term plan. So it should be that anyone who is attending hospital as an inpatient, so that would include mothers who are going in to give birth, we are all entitled to receive some smoking cessation and some brief intervention, and that's what we would be looking at for Surrey. I don't know if anyone else is doing this nationally. We also be really keen if this was offered to parents where children go into paediatric wards overnight as well, so to an offer for those families. And we're really keen, and this is what it says in the NHS long-term plan, that it should be an opt-out rather than we're asking parents to opt in. It should be like an automatic referral for that service. And that's really important, isn't it? Because not everyone feels confident having those conversations with parents. So we know you're more likely to quit smoking if you access a service. There's huge amounts of evidence about that. So it's about supporting families to get to that service.
Thank you. Yes, that first conversation may be the turning point, or it might be 5 conversations down the line that becomes the turning point. But if they always say no, then it never gets to that first point, does it? Thank you. Amy.
Yeah, so in Sheffield, our smoking cessation team does see inpatients. They go around every ward and see every child, every parent, and ask if they smoke or vape, and then they offer the service. The only thing, I worked on a medical ward for 15 years before I did this job, and the only thing that I found with parents is it's already a stressful situation being in hospital with their child, and the last thing they want to think about is the thing that relieves their stress is going outside and having a cigarette. So I think a lot of families weren't taking up the offer because it was a stressful situation, and that was the one thing that was sort of helping them. And then the other thing as well, I think once the families said no, they didn't want any support, they were sort of never asked again. So if, for example, if they were in for a week on day one, they said no, they were never sort of revisited. And potentially as that stress eases, or they maybe had a chance to think about it, it would have been good to sort of go back and say, I know last week you said this, but I've had time to think about it. If you looked at the information we've given you, would you like any help now? But it is something we do for all inpatients at Sheffield Children's Hospital.
Brilliant, thank you. And there does come a point where you don't want to be hassling people, isn't there? You don't want to be over asking, but yeah, sometimes going back and just checking can make a difference. But the other thing I also think is about those nuanced conversations, that if a parent isn't ready to stop, and that's absolutely their choice, are there other steps that could be taken to minimize it? So are they smoking outside or inside? Are they washing their hands? Are they changing their jumper? Are they cleaning their teeth? All those little things that might help reduce the risks just a little, but actually don't mean that they have to stop smoking too. That can sometimes be a step in the right direction for the safety of their child, but without them having to feel like they're making a big decision. We are coming up to 40 minutes, so Heather, I'll get you to be the last person. Thank you.
Just from a midwifery point of view, so in Guildford we do have a smoking cessation team, and again it started maybe about a year or so ago, and all staff, all midwives are trained with the very brief advice, so that they give that at booking, and they will continue to. And they do home visits, they'll phone women. We've got maternity support workers who will phone them and keep in contact, text, see them at home, whatever they want, whatever helps. And we actually received funding so that we can help them, provide them all the nicotine replacement. And if they set a goal date of quitting and they meet that, they get loved of shop vouchers and get that constantly. So it's doing really well. I couldn't tell you numbers because I'm not in that department, but they've been doing really well at reducing the amount of women smoking, and we know that if we can get them to stop smoking before, I think it's 15 weeks, we can reduce the risks in that pregnancy to that of not smoking. So that has been doing really well. If it was to be rolled out, then that would be brilliant. It all comes down to funding.
Doesn't most things. Yeah, absolutely brilliant. And Nicola's just put a lot of evidence about the provision of the cost savings versus what you get the other side. So yeah, no, thank you. We'll just, okay, Lotus, one more then. We'll go one more because we've still got a little bit of time.
Sorry, Nicola. I was it's just sharing the learning. It came out in one of my cases where in the safe sleeping practices where obviously really successfully handed down or given by the midwives and the health visiting, and they even had like the home visit and all that. However, it wasn't part of the conversation that came out that where in case like, will the baby be there, X number of times, will be staying there, or this baby will be brought to family members, visiting the family members, or leaving onto moms or grandparents. for a number of years, where, you know, safe sleeping practices or what that looks like, you know, in future or when they are visiting. And unfortunately, this baby, you know, there was a party, was introduced to the rest of the family members, and sadly the baby died. And there was some risk factors of alcohol there, co-sleeping, you know, and that. So whether it's just a reminder for you know, colleagues, and to include that sort of conversation with families, I suppose, you know, are they planning to visit grandparents and, you know, or any other family members, and will be staying there for X number of time, you know, and like just part of that conversation about safe sleeping, should, you know, they stay there for that longer period. Yeah, that's
Yeah, absolutely. And that brilliantly brings me to my kind of closing, is the fact that we do have these other sessions. So today was about opportunities and difficulties and challenges that we might face. But our next one, like I said, is the role of fathers and the wider family. We will have one about culture, and we've also, the other one I was thinking about is the deprivation and how that directly impacts that SUDI prevention as well. So Stacey, hold on to all those thoughts and bring them to that session, definitely. Because all of these things, and this is about building that professional curiosity, is thinking outside the fact that we give this message, so why didn't they follow it? Because actually there's a multifactorial kind of picture of why parents choose some bits and not other bits, and if we can understand where they're coming from a bit, then we can nuance those messages to be more meaningful for those particular people that we're having the conversations with. I'm really conscious that we have lots of people on the call who are not health background, particularly on my screen at the minute. Paddy, I can see you there from Surrey Police. I hope this has been useful for you as well. I know that obviously you don't work in a hospital, so a lot of the hospital-based kind of stuff is not something we can take back. Simon, thank you. We now ensure Prevent is delivered on all of our Skydip and child protection training sessions. So yeah, thank you. Just making sure that these messages are getting out. I think the one thing we're trying to make is that this SUDI prevention, no matter how small that conversation may be the thing that tips or triggers or changes. And I know obviously from a police point of view, that frontline police officer going into that house might see things that are a risk. And whilst they may not feel confident to have those conversations with families, they might be able to signpost those families to health visiting services or whoever as well, to kind of make sure that we can get those prevention messages in there as well. So thank you so much to everyone for today. We'll bring that to a close, and Nicola can stop the recording. Thank you.